Namaste and greetings. I, Fiza Mahajan, visiting researcher at IMPRI, Impact and Policy Research Institute, प्रभाव एवं नीति अनुसंधान संस्थान नई दिल्ली, extend my warmest welcome to you all to IMPRI Web Policy Learning. Today we are gathered here for day 3 of Healthcare and Gender Equity, Emerging Dimensions, Policies, Impact and Way Forward, an online international Monsoon school program, a 4-day immersive online hands-on certificate training course. This training program is organized by IMPRI, Gender Impact Studies Center, GISC. The chair for this program is Professor Vibhuti Patel, Visiting Distinguished Professor, IMPRI. This program has an excellent panel of experts who will be sharing their expertise for this 4-day online certification course. The distinguished expert panel includes Professor Poonam Naik, Professor Mala Ramanathan, Dr. Aqsa Shaikh, Professor Sangamitra Shilacharya, Dr. Amar Jesani, Ms. Sangeeta Rege, Dr. Padma Deosthali, and Professor Uma Kulkarni. The conveners for this course are Dr. Veena Vaswani, Director, Center for Ethics, Professor, Department of Forensic Medicine and Toxicology, Yenepoya, deemed to be University, Mangalore, Farhad Yenepoya, Pro-Chancellor Yenepoya, deemed to be University, Mangalore, and Dr. Simi Mehta, CEO and Editorial Director, IMPRI. Participants would learn from globally and nationally renowned thematic experts and practitioners. They will gain first-hand insights and networking opportunities. They will get course outline and reading list from the experts for learning, get access to session videos for 15 days. They will receive a certificate of completion and have the opportunity to publish their essays on the IMPRI Insights blog. I welcome you all to this enlightening deliberation and thank you for putting your time, energy, and efforts into truly understanding the healthcare and gender dynamics and their intersection in the current scenario. Before we start today's session, I would like to announce the housekeeping rules. It is imperative that you join the meeting on time. There will be a Q&A session after each presentation. Share your questions in the Q&A box and not in the chat box. The questions must not be posted as an anonymous attendee. Ensure that your questions are precise and refrain from making general comments in the question to save time. Our session for day 3 will cover topics of health systems response to gender-based violence by Dr. Padma Deosthali and response of healthcare system with regard to gender diversity and intersectional marginalities by Dr. Aqsa Shaikh. Now, without any further ado, I would like Professor Vibhuti Patel to take over from here and give us her remarks.
Yeah.
Over to you, ma'am.
Yes. Yeah. Thank you, Fiza, for giving this introduction. First of all, I would like to offer my heartfelt thanks to Professor Farhad Yenepoya, Professor Pro-Chancellor of Yenepoya, deemed to be University, Dr. Arjun Kumar, Dr. Simi Mehta, Dr. Veena Vaswani, Dr. Vithita Jha, Fiza Mahajan, and Ms. Vaishali Singh. And welcome Dr. Padma Deosthali and Dr. Aqsa Shaikh. And good evening, participants. First, let us have a recap of the previous session. Day 1 talked about the macro issues and provided the framework of the course by discussing the gender implications of health policy, social determinants of healthcare and gender equity, and gender in medical education. The Q&A session was extremely lively and we exceeded the time limit by 1 hour. And yesterday's session, they were about the question of gender in medical education, the question of human rights in health concerns, and we also had a very good presentation by Madam Sangeeta. First presentation was by Professor Sangamitra Acharya, who spoke on pandemics, epidemics, and gender and healthcare system, where she underpinned some of the important areas of intersectional marginalities and vulnerabilities that were faced by different sections of society. She also provided the history of pandemics and epidemics. She gave an example of Ebola in African countries and how women had to face the mortality and lot of hardship because there were no guidelines were given. And the global pandemic also taught us so many lessons about how you can't say that virus affects everyone equally. It is a social positioning of the people that determines what kind of predicaments they will face. So she also spoke about the problems that home-based workers face, informal sector workers, migrant workers, vegetable vendors, and women's reproductive rights, how they also got compromised because it was not treated as an essential service. And she said that it is very important to learn from such health emergencies so that for future we are prepared. And after her session, there were so many questions were asked by the participants about the question of medical negligence. Then question of we had a good discussion on who do you call quack. So she unpacked and deconstructed the term quack and how the traditional healers get marginalized when we use such this thing, and we focus only on allopathy. And she also talked about the Ayush and the plurality in the healthcare system, and how we need to understand more about that, and we should keep our minds open about the newer and plural forms of healing. After that, Professor Mala Ramanathan's presentation on visibility of gender in health statistics and health indicators, they highlighted on the data sources, especially the metadata sources at the health statistics that we have, gender differential beyond sex differential. She said that why we can't only focus on the biological, but even the gender issues and going beyond binary is very important. She also said that only numbers don't mean anything. We need to have indicators and we have to give the weightage according to their significance. She also introduced the participants to data and also analyze the data of census, SRAs, which is by the Ministry of Health, the Ministry of Home Affairs, NSSO data by MOSPI, Ministry of Statistics and Planning and Implementation, NFHS data, HMIS data. There was a very good debate on the multi-sectoral policy about the poverty, multi-dimensional poverty indicator, which the Niti Aayog has floated. With all the criticism of NFHS data, Niti Aayog has also depended on the NFHS data, NFHS 5 data to come up with this multi-sectoral health indicators. And she also talked, she ended with a very interesting note, and she said that we need to have an archaeological expedition in data and to identify the gap in men and women, and also we need to standardize our data in a very, very careful manner. And she said interpreting data in a right manner would always lead to the right kinds of policies. And she also answered the question methodology. The question asked right will also result in a very appropriate and right answer. So it is very important how you conduct your research. But it was both the presentations were extremely nuanced and very helpful to the participants. Thank you very much.
Thank you so much, ma'am. Now, I would request Professor Veena Vaswani to provide her opening remarks before we move on to the presentations today.
Sure. Good evening. So, welcoming you all to the third day of the Healthcare Gender and Gender Equity, Emerging Dimensions, Policies, Impact and Way Forward. Whenever we have been discussing, there is a common connotation amongst people that we have done some good things in gender, that we are moving forward, but then we are not looking exactly like Vibhuti madam said, the data, what does it say? And when the data says something, are we in a position to accept it? Or do we think that we are beyond data? So it's important that the data, which is directional, we need to follow it in a true sense and the spirit, and not just go by the number, because there is always a gap in the system, and that gap shows where we need to focus our energies. But rather, many a times we look at data in a very skeptical way. But if the data is collected like an authentic science, it can be directional. So I do think that it's not like throwing the baby with the bath water out, but see what can be done to bring in more and more success to the endeavor at hand. So we need to look at the task before us. So with that, I would like to pass on the mic back to Fiza.
Thank you so much, ma'am. Now I would request Dr. Padma Deosthali, Program Director, Creating Resources for Empowerment in Action, CREA, to begin her session on the topic of health systems response to gender-based violence. Looking forward to an insightful session, ma'am. Over to you.
Thank you, Fiza. Thank you, Professor Vibhuti and Professor Veena. I'm grateful for this opportunity given to me as part of being part of this course. And I'm here to share my learnings around what health systems response to gender-based violence means, what are the challenges, what is the mandate, and we can also spend some time on some discussion. So just to kind of quickly give an outline of what I have planned for this time that we have till 7. We will talk about the role of health systems, the policy and legal mandates. We'll then focus mainly on understanding response to sexual violence, looking at it as one case study. And then I have about 4 or 5 case studies which we can open up for discussion. There's a short film that if time permits, I can show at the end. Otherwise, I will share it with the group and you can watch it later. To begin with, when we are talking about gender-based violence, and if you see the course outline, I think the course organizers have specifically used gender-based violence. Often gender-based violence and violence against women are used interchangeably, but they are not the same. So violence against women, as it clearly states, it is violence against women. Often it's also violence against women and girls, which would include intimate partner violence, domestic violence, rape, sexual violence. Gender-based violence, on the other hand, is broader than violence against women because it includes all forms of violence based on gender. And therefore, it also includes sexual and gender diverse persons. So, violence that is perpetrated on them because of gender norms also is included. So gender-based violence is a broader term. And just to, emphasize that they are not the same and we must use them, with caution. Why are we talking about health system? I think that's one of the, core issues here. One is that survivors, victims of violence, any form of violence, may come directly to the hospital for treatment because violence has health consequences. Any form of violence, whether it is physical, sexual, emotional, or financial abuse, will have a health consequence. Whether it is, it could be direct or indirect. And that at some point, the person is likely to reach a health facility or a health provider. So they may come themselves, or in some cases, the violence may lead to death or very severe health consequences. So they may be brought to the hospital. And all forms of violence here get reported, whether it is domestic violence, rape, whether it's police torture. And when I say domestic violence, it includes parental abuse, not only against girls and women, but also sexual and gender diverse person. We've heard about domestic violence faced by transgender groups, by, those from the same sexual orientation. So, all kinds of violence, physical, forced treatments. So all of that, there will be an interface with the health facility. And therefore, we are talking about the role of health systems. Secondly, survivors who are facing violence may or may not report violence to the police or to the criminal justice system, but they'll definitely meet health providers for treatment. And therefore, the health systems play a major role in providing treatment, psychological support, and also connecting survivors to violence against women services. Now, what is the global consensus around responding and response of health systems? And I quote from the WHO Clinical and Policy Guidelines of 2013. where the guidelines clearly mandate and clearly state that all health systems, and irrespective of the development of the country. So it's not something that only the well-developed, highly developed health systems can provide, but it says that even low middle income countries, all health systems must provide supportive care. Now, what does this supportive care mean? The supportive care means that health providers must listen to the survivor. So empathetic listening, ongoing psychological support, and referral to other services. There's evidence, and that's quoted in those guidelines, that supportive care contributes to prevention of violence recurrence and mitigation of consequences. And how does it do that? Because moment you provide supportive care to a survivor, she is able to, increase her capacity to stop violence by using better safety planning. And it also eventually improves her health and well-being. The other role of health system, as mandated by the guidelines, is documenting violence, emphasizing its health burden, and advocating coordinated action with other sectors. And I just want to clarify that the WHO guidelines are around violence against women and girls. So they are not around, they have not, because they have looked at evidence around what works when you're responding to women and girls. Coming to India, the health policy recognized gender-based violence as a health issue only in 2017. So one aspect which I think has been covered in day one of the course is the health policy recommendation that all hospitals must be, staff and facilities should be gender sensitive. The second one is more around ensuring that the survivors of gender-based violence are provided treatment and are treated with dignity. So this is something which has come only in 2017, but better late than never. But even before these policy guidelines came in 2017, there is a legal mandate for healthcare providers since many years. And we'll look at some of these very quickly. One is the Protection of Women from Domestic Violence Act of 2005. We'll come to what it says. Then the mandate on doctors to record dying declaration and what is it that they are supposed to do. The Criminal Law Amendment of 2013 and the Prevention of Child Sexual Offences Act of 2012. Now, as per the Domestic Violence Civil Law of 2005, one of the roles that are mandated for healthcare providers are identification of abuse, documentation of the current episode and past episode of violence, providing immediate medical treatment, which is free of cost. So you cannot charge a survivor for, any kind of medical care. Lastly, providing emotional support and also informing her about provisions under the law. And if they don't, and refer her to a protection officer. So this is clearly mandated as far as the health providers are concerned. Coming to dying declaration, this is mostly in cases of burns or any other suspected violence where there is a chance, there's a possibility of death. And this is the role that has been carved out for doctors, where they have to certify that the person is capable of giving a dying declaration to the magistrate. So if there's a woman who's come with very severe burns and there's a chance that she will die, the magistrate would be called in to record a dying declaration, a provision that came into law after a lot of activism by the feminist movement in India. And the law also says that if no one is available, then the doctor must record the dying declaration. So it's not enough to say that the magistrate didn't come, but if the magistrate is not come and as a doctor, you feel that there is a chance of death, then you must record the dying declaration. The Criminal Law Amendment of 2013 is critical because it has broadened the definition of rape to include all orifices. And it also has, under section 357, mandated that all public-private hospitals must provide treatment. So in a way, it is the first time that right to treatment of rape survivors has been recognized in law, and that this treatment must be provided immediately and free of cost. It also has included a penal provision under 166B of the IPC to say that if any facility or doctor contravenes these provisions, then there could be imprisonment for 1 year or fine or both. And this recognition has come because, and I'll come to that a little later. What are the challenges? If all of this is mandated in policy and law, then the biggest challenge, and I'm sure you're discussing it in the last 2 days, is the biomedical model of the health system, which does not allow survivors of domestic violence or other intimate partner violence to come out and speak about what is happening and disclose the cause of injury or ill health. Secondly, often violence is seen as a social or criminal justice issue. So it's an issue which the police should look into. It's not something as doctors or as medical professionals we should look into. So these are all barriers in responding, actually. There is also a failure on part of health systems to understand inequalities within society. So they are not able to really look at social determinants of health. So they just want to restrict themselves to treatment. So they don't want to get into the cause of the injury or cause of the infection, which both could be violence. Healthcare providers also may share the dominant sociocultural norms that allow or normalize violence against women, violence against sexual and gender diverse persons. So they also are caught in gender binary. So they may also be transphobic, they may be homophobic. They also feel that it's okay if women are beaten up if they don't follow their husbands. So those kinds of gender norms are commonly held by doctors. There's also disrespect and abuse in reproductive health systems. There's violence in labor room. There's forced treatment of sexual gender diverse persons, which will prevent patients to even open up when the system itself is so insensitive. Very quickly, let's look at when we say health system's role. Health system does not operate in isolation, and it works with other institutions. And in the case of sexual violence, let's see what happens to a survivor and what are the kinds of intersections with other systems. So you have the survivor at the center, and the survivor would have to deal with the health system, the police, the family and community, and also the judiciary. When it comes to health system, there's an inertia to respond. There's a preoccupation with injuries. So if a rape survivor does not have physical or genital injuries, there's a common perception that probably rape didn't occur or she's telling lies. There is a whole preoccupation with past sexual conduct, whether she was sexually habituated or not. There have been multiple orders of the Supreme Court and guidelines by the Ministry of Health, but this kind of these practices continue till date. There's an absence of reasoned medical opinion. So the doctor will carry out an entire detailed examination, fill out an entire 4 to 6 pages form, but will not say what is it that what is the clinical medical opinion. So based on the history and the clinical examination, what is the opinion that the doctor has formed is mostly absent in these medical legal forms. The most glaring gap is that this the preoccupation with medical legal examination is done at the cost of provision of care. So there could be unwanted pregnancies because UPT was not done. There could be infections because there was no testing done in time, and there's a complete absence of psychosocial services. Coming to the police, there are lots of biases, reluctance to file FIRs, there are delays, they may be asked to keep coming back. Our work with survivors shows that mostly they had to go to a police station at least 4 times before, their case was registered. The police often come to health facilities with questions such as whether rape occurred, whether the victim is habituated to sexual intercourse, whether the alleged victim is a virgin. I mean, I'm sure all of you here would understand that none of these questions can be answered by a doctor, and they're totally irrelevant to the complaint of sexual violence. But that's how the police operate. And if a facility does not answer these questions, often they'll just keep taking the survivor to multiple institutions. The forensic science laboratories, many of us feel, are these scientific, places where things will be done so well, but we don't understand what's happening there. There are no standards laid down for these FSLs, which may be a surprise, but that's the fact. The evidence that is collected, its management from the time it is collected from the body of the survivor, it may not be dried and sealed well. It may be lying in the hospital. It may be picked up by the police and it may keep lying at the police station. It may not be preserved at a temperature at which it should be preserved. So often by the time the FSL receives it, it is totally useless because it cannot be examined or tested. There could also be tampering because there's no documented chain of custody. There are delays in receiving reports because most FSLs are overburdened. And if you look at FSL reports, and which we have seen closely, mostly they say inconclusive. So, this whole notion that a medico-legal examination and forensic evidence will tell us whether rape occurred or not itself is totally unscientific. Coming to judiciary holds similar stereotypes of rape. There are several biases. So, if you look at the orders of the Supreme Court, you'll find that convictions are likely in cases where there are injuries present or where the victim is a virgin. So the judiciary also has certain biases that are very evident. There is a lack of understanding of medical evidence and its limitations. I'll just give an example of a hymenal rupture in a minor girl. So that's the medical evidence. And the Sessions Court, convicted the perpetrator, saying that the injury caused because of rape. The High Court interpreted the same medical piece as ruptured hymen is evidence that she was sexually habituated and so not of a good character. Finally, it was the Supreme Court that accepted it as an injury caused by rape. Apart from that, survivors have to deal with their own families who often blame them. They control their mobility after the incident. There's the community where there's again victim blaming. There's ostracization. So once the case is reported, because most of the times the perpetrator is from the neighborhood. So, people will not support the survivor and her family. They are forced to relocate. With children also, we found that schools have asked children to leave until the case is going on in court. And often families have also discontinued them from school and colleges. Coming to the clinical guidelines issued by the Ministry of Health, these came in after a lot of advocacy and work with health systems to really identify what is missing as far as the medico-legal response to rape survivors is concerned. And they are very detailed, and I hope most of you can look at it. But they include informed consent for all stages. So there's no blanket consent. So we cannot assume that because a rape survivor has reached a facility, she is consenting to the entire procedure. So it mandates that the provider seeks consent for all stages of the examination, evidence collection. It also tells them how to document history, how to seek history, how to collect relevant evidence, not just mindlessly pick up swabs from all parts of her body, but do it only if required based on the history that she is giving, treatment and psychological services. And it clearly says what not to do. So, all the insensitive practices about commenting on the hymen and all of that are clearly stated that you should not do. Treat hymen and vagina as any other part of the body. So if there's an injury or edema or bleeding, you mention it. Otherwise, there's no need to say whether a hymen is present or absent, or, what is the size of the vaginal introitus. All of that is not to be done. There are also specific guidelines for responding to marginalized groups. And marginalized groups here are defined as those facing discrimination based on gender identity, where an individual's body doesn't fall in the rigid binary of male-female genitalia, sexual orientation that they practice, persons who are engaged in sex work, also physical, social, psychosocial and intellectual disability, and religious minorities, castes or tribes. And the guidelines of 2014 of the ministry clearly recognize these and given very specific ways in which providers must respond to survivor coming from any of these marginalized groups. So it says that you must not demonstrate shock, disbelief or ridicule, and ensure that none of your own biases come into your doctor-patient relationship. It also says that you must acknowledge the challenges and obstacles faced by these groups in accessing health services. And therefore, it's the mandate of the medical professionals to create an enabling environment at the health facility. Now, just a few things to say, look at whether we know, whether we are clear about what the law says. So if, I mean, I can't see hands raised, but, or I think it's 6:34. Is it mandatory to inform police? Would people like to respond, or should I just, given the time, maybe I can just go ahead? So
the participants can raise their hands and then
okay.
they can speak. Yeah. If anyone wants to answer.
As far as I know, it is not mandatory to inform the police for the patient, I mean, reporting. But I don't know if it is mandatory for the healthcare workers to inform the police.
Okay. So you're right. Survivor need not go to the police first and then come to the health facility. Survivor can go wherever she or he or they want. But mandatory reporting is by the health professionals. So under POCSO 2012 and 357 CRPC actually say that yes, the doctors must inform the police. The guidelines of 2014, which were framed after these mandatory reporting laws came in, talk about informed refusal. So they say that if a survivor does not want to inform the police, then you must document refusal. You can't assume that the person has to be reported. Documenting it as a medical legal case is adequate. So that is what the guidelines say. There are problems with mandatory reporting, which I would like to just highlight here. The mandatory reporting laws have come in India, so they are here to stay. But just for us to understand that mandatory reporting affects care and treatment. Because if a survivor only wants treatment and does not want to go, report to the police, the mandatory reporting law makes it impossible for her to access services, because then they are likely to not reach the health facility for treatment. The MTP law says that all women seeking abortion, all their information must be kept private and confidential. But moment you have abortion is a consequence of an unwanted pregnancy is a possible health consequence of rape. And when survivors come in for abortion, and if you report to the police, you're also violating the MTP Act. So it does break the confidentiality and privacy trust between doctor-patient. And internationally, if you see, the mandatory reporting is to support services and not to the police, because mandatory reporting to police creates a huge barrier in accessing care. Is it mandatory to go to government hospital for sexual violence examination? So I won't spend time in, seeking answers. This is something that bothers a lot of people. People assume that it is only government hospitals, but the law does not say so, nor do the guidelines. You can go to any registered medical practitioner In fact, the amendments in 2013 make it mandatory for private hospitals also to respond to sexual violence. Is it necessary for a female doctor only to examine sexual violence victims? So again here, we must remember that as per the section 164, it says any registered medical practitioners. It does not say woman, but it's only POCSO, the Act Against Child Sexual Abuse, which insists on a woman doctor for girl survivors. But 2014 guidelines recognize that all facilities across India may not have a woman doctor available immediately. And therefore, they say that every possible effort should be made to find a woman doctor. But if not available, then a male doctor in the presence of a female staff can go ahead and examine. Who can be present while the doctor conducts examination? It has to be only the doctor if it's a female doctor. But if it is a male doctor, it could be any female staff. As per section 27 of POCSO, it also allows for someone that the patient trusts, and that person can be present during the examination. Now, are past sexual practices, included in sexual violence examination? And very clearly, there are several orders of the Supreme Court and amendments to the law which prohibit any kind of comment about past sexual history of the survivor. So whether it's the two-finger test, old hymenal injuries, past pregnancies, abortions, use of contraception, all of them, built of the survivor, the height and weight, all of these are not to be documented in the medical legal examination. Is it necessary to do age estimation? These may be done only in borderline cases. And there is a Supreme Court judgment of 2012 which says that if documentary proof of age is available, then there is no need to do age estimation. So this assumption that anybody who's below 18 has to undergo a age estimation, because it's also adding unnecessary medical procedure for survivors who are seeking health services. Now, what is medical evidence? So medical evidence is trace evidence, which could be semen, spermatozoa, blood, hair, any kind of dust or paint or fecal matter. So that may be on the body of the survivor. It could also be injuries. So there could be bodily, physical injuries or genital injuries. Often genital injuries are, micro, they are very small injuries which heal very fast. They are difficult to, they are not visible very easily. There could be abrasions, lacerations, other kinds of injuries. STDs also are medical evidence. So, any kind of sexually transmitted diseases could be medical evidence. Evidence of treatment. So if the person is in pain, that itself should be considered as evidence. If she's depressed, if she's suffering from any infection. There are limitations of medical evidence, and it all depends on when it was done. So that documentation becomes important because if there is a time lapse from the when the incident occurred, there are chances that the mucosal injuries may have healed. There could be urination, defecation, which may wipe out any trace evidence from her body. If there is any use of condom, then you're not likely to find any evidence on her body. But one must remember that no medical evidence does not mean that no offense took place. And I think that is the crux of the health system's response to rape, to be able to, because they are the only ones who can spell out the limitations of medical evidence and not essentialize it. Is it relevant to document when the examination was done? Yes, because that is going to determine the interpretation of the examination. The history must also mention if the person has cleaned herself, washed herself, and Yes, and an opinion must be formed by the doctor. I'll stop here for any questions. We'll come to the film only if we have time. Otherwise, I'm going to share it. So if there are any questions,
Yeah.
I see that there's one question there.
Roshni, can you unmute and speak?
Yes, please. Hi, I'm Roshni, and I am a public health researcher and an ethicist. And I have been wondering, listening to all the conversation that has been going on regarding acceptance of marital rape in the Indian context. And there is a whole lot of opposition, but I do not understand why and how this conversation is being held. So if you could throw some light upon that, I would be grateful. Thank you.
So as far as the health systems are concerned, I mean, they have to recognize it as violence and carry out the medico-legal examination. And that's what the guidelines and protocols clearly mandate them. So whether or not it is a criminal offense, that is a legal issue. So that's for the courts and for the survivor. But as far as health systems are concerned, they are expected to carry out the entire medico-legal examination as they would do for any other rape survivor. I hope I have answered your question, madam.
But also it contributes to, it strengthens the case of women under the Protection of Women from Domestic Violence Act. No? So women are now, because there is no law, this law, at least it gives the added reason, no, for the justice for the survivor, if the medical examination is done.
Absolutely, absolutely. And it's only the criminal law that does not recognize rape by a husband. Domestic violence clearly says that forced sexual intercourse is a form of sexual violence. It defines that as form of sexual violence.
Yes, that's what I was looking for. Thank you so much.
Okay.
Yeah, of course.
Sasha Nijharaji, you can unmute yourself and ask your question.
Thank you. Hi, ma'am. Thank you for the great session. I am a public relations consultant working closely with social impact organizations. And one of them is highly working towards public health and gender-based violence. So I have two questions for today. First is, I asked this to Ms. Sangeeta ma'am also on the first day. Are there any resources that we can use which encourage inclusivity in our language, in our everyday language, so that gender diverse people, when we want to include them in the conversation, they don't feel offended by just the terminologies that we use. One of the books has been organized with from my organization as well, but if there are any multiple resources that we can refer to and educate ourselves on everyday basis.
Yes, there are multiple resources available, and I can definitely send links to that. I work with an organization called KRIA, and we do a lot of work around sexual and gender diverse persons and gender-based violence, really, and looking at that. So I'll share those resources. Thanks for that question.
Thank you, ma'am. Ma'am, there is one more question.
Yeah.
Actually, again, as a person who is closely working with social activists and social impact organizations working towards gender-based violence, the things that you discuss, especially the policies part, even as a woman, I am 27 years old and I was not aware of these policies that well. So as social impact organizations, what can their role be to educate a layperson into this? What are the kind of maybe articles, blogs, or awareness, educated material that social impact organizations can create? And maybe I can use your opinions for my people, the people I represent. I can also share with them that maybe you can write an article in media for this so that more people are educated. We as women are not educated about that.
No, I think there's much more needs to be done as far as awareness is concerned. And one of the things, it's not just social impact organizations, even, there's little recognition that right to treatment is now enshrined in law for rape survivors.
Yes.
So I agree that much more needs to be done. And, people like you can also write about it and create awareness, because if we know what our rights are, then we can stop these practices and we can question the health systems and health professionals if they do violate any of this.
Yes, ma'am. Thank you.
There's one.
John, would you like to unmute and ask your questions?
Ma'am, I have a few questions. I hope I'm not overindulging your time. So the first question was regarding sexual abuse in group homes. Is there, especially those run by the state, is there some specific procedure to be followed in reporting of abuse in these cases, and also in rehoming in these cases?
That's a good question. And, these homes are supposed to be for protection and safety of young children, and abuse should not happen. They're supposed to have regular medical checkups. They're supposed to have interface with nurses and doctors. There's a whole staff. So procedurally, there are opportunities to identify, but it's not so easy. And you may have seen what happened in Bihar. It's only through a social audit that the Tata Institute was undertaking that some of these survivors, some of the children came forward and disclosed about the rampant sexual abuse that was happening in institutions. But if you're saying about tools, yes, there are existing tools, John, and NIMHANS has an entire, I can probably send the link where you can also look, Google it. Dr. Shekhar Shekshadri has developed tools on how to speak to children so that they are able to talk about what is happening in their lives. Because children are not able to speak, they don't have the language. So there are these forensic tools that are available that psychologists and counselors can use.
Thank you, ma'am. Sorry, I forgot to introduce myself. I'm Aquilin John. I'm a student of psychology. I have worked with Childline India as a volunteer. The second question I had was regarding a more modern concept that has come up, which is stealthing. I don't know how much people have been made aware of stealthing, which is the non-consensual removal of condoms during sexual intercourse. Are cases like these taken seriously when reported reported at all? That is the first thing. And the second thing is does the healthcare system recognize it as abuse?
Yeah. Okay, so reproductive coercion is a form of abuse which is recognized as abuse, but your question is, I won't say that health systems recognize it. They must recognize it is what I would say. Whether it is reported, it's very nuanced. It's very intimate. So where, we are in a situation where even forced sexual intercourse or even painful, use of objects by intimate partners is also often not reported. So,
but it becomes a social issue, Padma, when sex workers are also reporting, no? That is what is happening with them.
Absolutely.
And for them, it is such a big burden, no? Unwanted pregnancy, backdoor abortion, health hazard, loss of business also for them.
Of course.
There are questions by Amruta Girish. Would you like to unmute, Amruta ji?
Yeah. Good evening, ma'am. I'm a development professional. My first question was if healthcare practitioners suspect domestic violence in a regular checkup or other treatment, are they legally obliged to report it to authorities?
Yes.
And the second was if you can throw some light on reporting of violence by sex workers in the transgender community.
Yeah. So the answer to the first question is that if somebody is reporting rape, then as per these mandatory reporting laws, they are mandated. If somebody has not disclosed it, they are supposed to identify make that person comfortable and refer her for psychological support. So they are, as per law, they must identify abuse. So if they suspect that this may be a cause of violence, yes, they must, so I won't say report, but I would say that they are supposed to respond and provide her services. So that's the answer to your first question. The second one, sex workers, and I'm glad that Vibhuti raised it. And that's why the guidelines have an entire section on how to respond to survivors of rape who may be sex workers, because there's this presumption that because they are engaged in sex work, they cannot be raped. But sex work is their work. And there is rampant rape by the police. There's rape by, people who may not be their clients. And there's corruption. There is a lot of different kinds of even physical violence that sex workers are facing. Transgenders, yes, they find it very difficult. Transgenders and homosexual men, they find it very difficult to come to health systems because they don't know how they will be treated. So we've often had calls from transgender community and homosexual men, and we've always encouraged them to come to facilities where there is a sensitive response that has been set up, so that the reporting will not happen and they will be treated with dignity.
According John, your second question, would you like to ask our private, or we can postpone it?
We can postpone if there's, but if there is, it's possible.
Yeah, I think we can ask later on. So,
yes, no.
Garima Agarwalji, can you unmute and ask your question?
Yeah, thank you so much for this opportunity. Dr. Deosthali, I was wondering about the one-stop center scheme that the Ministry of Women and Child Development introduced quite a while back, and how that has not come up in this entire conversation of addressing gender-based violence, and especially violence against women. And I was just wondering about your perspective on the status of how this scheme has soared in the past few years, and what are the type of challenges that this scheme faces in its successful implementation.
Yeah, that's a big question. I'll give a short response and maybe, I'll spend some time answering your questions after, once Dr. Aqsa takes over. I will try and answer all your questions, but the one-stop scheme is complex, and the whole idea was that it will provide services to rape survivors. But if you go to these centers, you will find that rape survivors don't reach there at all. So the maximum if you look at that profile, they are largely domestic violence survivors or elopement cases. You will find elopement cases in any facility that you go, because the police would have, picked up the girl, and they will drop her to the one-stop center for 5 days, because 5 days is the shelter available. And then they will move her to a women's shelter or institution. So that is where the one-stop centers are. They have not been able to set up a coordinated response to rape survivors. So even if rape survivors are not reaching there, one-stop center staff is not going to the police or the health facility where rape survivors reach. So that's a really sad state of affair. Most of the cases reaching one-stop centers are domestic violence. If you look at the response of these one-stop centers, they are mostly towards intervening to get the couple to sort out their differences and live together. So it's all about samjhauta. And it is not from a feminist perspective, or clearly saying that there will be no violence in future. So it's all about preserving marriage.
Now, Madam Sonal D'Souza, would you unmute and ask your question?
Yeah, Dr. Padma, thank you for this wonderful session. I just want to ask you, what is the steps forward from a policy point of view to kind of build capacity in the law enforcement in sensitizing such issues? Because the two-finger test obviously is very deliberated and highly contested. How do you look at sensitizing? Because although there's policies, but I think on ground, the sensitization of law enforcement is not really there.
Yeah. Thanks, Sonal, for that question. And it gives, I would like to give an example of how this has been taken up by the Delhi High Court. And what the Delhi High Court has done is that it's brought in health professionals, police, and judiciary all together for common training workshops. And it brings in voices of survivors, it brings in medical professionals. So the entire capacity building is done for all the three sectors together. So there is some conversation amongst them. So the Delhi High Court has initiated that. And I think those are the kinds of innovative ways in which we have to continuously, tell them that this is what you should not do and this is what you should do. Yeah.
Now we can take your question, Aquilin John. Yeah, please go ahead. Are you there? Hello.
So I see their question. They're saying, are private hospital obliged to provide MTP care? Yes, they are, because for a rape survivor, as per the law, they must provide free treatment.
Yeah. Yes, Padma, now you can show your film.
Okay, so I think we'll skip the case studies, Professor Vibhuti, because I don't think we have time. We're almost at 6:59.
Yeah,
so
yeah. But I think you make it. How long is the film?
It's 4 minutes, so maybe I'll just share the link. No problem.
No, you can show the film. We still have time. No problem.
Oh, okay. Sorry. This is a film made by ICRW.
It's not sharing with us. Is it playing at your end now?
Is it not showing?
No, only link is showing.
Oh,
Film is not started. Yeah.
Okay, because it's run for about 1 minute on my screen, but I don't know why it's not showing.
When it is not in the screen show mode, it won't show. If full screen mode, and then you can click on the.
Yeah, that's what I did.
No, we were still seeing it in the, not in the screen. Now it will show.
Now.
Is it visible now?
Yes, it is visible. Yes.
I'm so sorry. I'm so sorry.
Start from audio.
Can you hear? Was it audible? No?
I think you'll have to go to this thing, no, and click on audio.
It takes some time, but no problem. Please let it run. Yeah.
Can you hear it now?
We can see it. It will come. Let it run.
Is it?
At your end, I think at a screen share, you'll have to.
It's
Go
still
for
not,
audio.
you can't hear it, nor can you see it, is it?
We can see it. We can't hear.
But you can't hear it. I'm sorry, I don't think I should waste more time then.
No. You can go to your, I think, to your left. And there, I think you'll have to make the audio on. Yeah.
Is this, can you hear this?
Arjun Kumar, just tell that, just give the instruction, no? How to start audio.
Is it still not heard, Vibhuti?
Ma'am, it will come. It
It's
takes some time. Yeah. Let it play. It will come.
Can you hear now?
No, ma'am, it will come. It takes some time. Let it play for 30 seconds.
In terms of providing
No?
No problem. Ma'am, you can share the link. We will share it over email also to everyone.
Ms. Akuma, can you unmute and ask your question? Hello, are you there?
Yes, ma'am.
Yes, Akuma. Yeah.
Good evening,
Hello.
ma'am. Thank you for the presentation. You talked about gender-based violence, and you said it's has a broader description or scope. So I'm just curious to know if there are cases of men, reported cases of men being molested or who are undergoing violence with respect to their spouse. So I'm just curious to know if there's any information on that regarding that, and what are the ways in which the society is seen men as superior or patriarchal in nature. How do they address such issues? Because there are millions of men undergoing violence in their houses and they are suffering in silence. So I'm just curious.
So you may be aware that the DHS has included an entire module to also look at and measure violence faced by men from their intimate partners. And that data is available for some countries, and it shows that the prevalence is very low. But yes, there are men who may be abused by their intimate partners. But you may want to just look at what those forms of violence are, and where men have reported. They have also said that it is in retaliation of ongoing violence from the man to the woman, and women have been violent as a response of ongoing abuse. But that data now that is available for some countries, you can look at the DHS data. I really want to apologize for this,
Yeah, and
the
whatever
fact
link
that
you
I will
wanted
share
to
the
share,
link.
no?
I
You
will
can
share the link.
share even on the text chat box so they can
I will
download it.
I'll
Yeah,
do that.
so because we have that facility of sharing the links.
Yes, Vibhuti, I'll do that.
Yeah.
My sincere apologies.
Yeah, thank you very much for a very lively session.
Thank you. Thank you, everyone.
Thank you, ma'am. So now moving forward, I would request Dr. Aqsa Shaikh, Associate Professor, Community Medicine, Hamdard Institute of Medical Sciences and Research, New Delhi, to start with her session on response of healthcare system with regard to gender diversity and intersectional marginalities. Over to you, ma'am.
Hello, good evening.
Good evening, ma'am.
Good evening, ma'am.
And it's really wonderful to be here again with another program and discussing a topic which is very close to my heart. And I really want to start this discussion by answering the question that Puma had asked with reference to men facing violence. And Dr. Padma had also mentioned that we are now measuring violence against men by their intimate partners. Now, there is another, I would say the hidden iceberg of violence against men, which is done in homosexual relationships, where the intimate partner is also a man, and the victim of violence is also a man. And it's difficult for the victims to come out and talk about their the violence that's being perpetrated against them, because that also means outing that they are gay men or queer people. It's difficult for them to go to a healthcare provider and seek help, because then it would be outing themselves to the healthcare provider that they are not just in a queer relationship, but also a victim of violence. And as a man, as Akum also mentioned in his question, to accept for a man to that they have been at the receiving end of the violence itself can be stigmatizing. And unfortunately, there is not much data available with reference to intimate partner violence that men receive, and from other men in a gay relationship, or that the trans men may receive. And that's something, which is something to research and talk about. Having said that, I'll be speaking about gender diversity. I'll be speaking about how healthcare is an important aspect when we talk about gender diversity, and what we have been seeing, what could be the way forward. I'll be using some slides, so let me just start sharing my screen for that. I hope the, yes. So, we need to first of all understand that gender diversity is a concept that still a lot of people do not understand. It's still being debated whether we speak about trans people entering women's sports, whether we speak about gender reassignment surgeries, or we speak about the debates on reservation for trans people. It's still a topic that our society has to come to terms with. And what we don't understand, we start fearing, and we often are afraid of trans people. And then they are judged as evil, as bad people, as sinners also. And then what we judge as evil, then we start to control, we start attacking, and that is how transphobia, homophobia, and various other forms of hatred that we see come up. And we also need to understand that in terms of intersectionality, trans people do not exist in isolation. They're not just trans, but they also may be following a religion and face marginalization on account of that. They may be a Dalit trans person, they may be a trans man or a trans woman, or a non-binary person. And then there are also other intersectionalities in terms of class, region, tribal identity, and so on. And somehow there is a lot of interaction that happens between gender identity and healthcare. When we speak about intersex people, for example, I'm sure this must have been discussed by now, that what's the difference between trans and intersex people is that intersex people are those whom you cannot put into the category of either a man or a male or a female at birth. We sometimes say ambiguous genitalia, sometimes it's called disorders of sexual development, which is not a good term to use, and we can say differences in sexual development. And right from there, the intervention of healthcare workers in the life of an intersex person starts. When it comes to transgender people, once they start having, a realization of their gender identity, and gender dysphoria kicks in, that affects your mental health. And then you need a healthcare provider to, provide you help to deal with this gender dysphoria. So, there's a lot of close connection between gender identity, between sexual characteristics, sexual orientation, and healthcare provision. And unfortunately, it's a difficult relationship, I must say. Now, before I go and talk about gender diversity and especially about trans persons, I want you to have an image. And look at this image, and this is the image that we generally associate with trans people. Also thanks to our media, and this is possibly the most visible form of trans people around. But I also want you to understand that there are also trans people like this. We have trans men or trans masculine people. And we also have people who are non-binary or gender non-conforming, who do not identify with the binaries of men and women. So when we speak about different gender identities, then not just three, but beyond these many gender identities is what we need to keep in mind. And though we say that it's a minority population and our census has measured it at around 5 lakhs, I would say it's an undercounting, understatement. And probably the actual number of gender diverse people may be 10, 20 folds higher. Unfortunately, we are not doing a census now. We don't know when the next census will be done. And, as it was mentioned, probably you might have seen it in the movie Tali also, is that maybe in our cities, we know the number of dogs, but we do not know how many trans people are there in our cities. And that's really very tragic, because if you are not counted, then you don't count. If you are not counted, then there is no estimate of how to provide healthcare to you, or how much finances to assign, or how many resources to give. A lot of trans people, as you know, do not get access to education, especially since trans identity, starts kicking from the age of around 3 to 4 years, which is also the time when you're entering schools, and therefore you have a very high chance of getting bullied, or maybe even abused. And therefore, the opportunities at education are very few. And therefore, a lot of trans people engage in traditional professions. This is not begging. It's called Basti Vadhai. They may also be involved in sex work, or they may do performances like dancing, blessing, etc. And as you know, for a very long period of time, trans people weren't recognized legally in India as a separate gender identity. We only had two gender concepts, or two sex concepts rather. It was the NALSA versus the Union of India judgment by the Supreme Court, which for the first time recognized trans folks as the third gender and talked about their rights. And those rights also included the right to healthcare, discrimination-free healthcare, and accessible healthcare. And there have been now a lot of landmark events, starting from 2014 with the NALSA judgment. Then the Indian Psychiatric Society's position statement came, which said that sexual orientation and gender identity cannot be and should not be changed, and that these are not diseases. In 2018, the landmark reading down of Section 377 came. 2019, the Trans Persons Act came. Then 2020, trans rules came. And remember, this was all happening when the pandemic had also struck us. In 2021, the convergent therapy was banned, again, thanks to another High Court decision. Then we had the health insurance launched for the trans people by the government. And now in the MTP Act, it talks about trans people also, and not just women, as traditionally mentioned in the Act. And there have been, I would say, a lot of, small incremental progresses that have been made in terms of healthcare for gender diverse people. The courts have taken a very stern view of the queerphobia that is present in our medical education, and the need to revamp that and Fortunately, the National Medical Commission has started that process by changing the curricula for 2 subjects at least, that's forensic medicine and psychiatry. So you might have heard about this, that, terms like sodomy or lesbianism have been removed. And there is also, for example, there was a question about the 2-finger test, and that's also removed from the curriculum. Then we had this, in the same judgment, the Madras High Court saying that convergent therapy, the National Medical Commission needs to do something about it. And then National Medical Commission said that it will be a professional misconduct. But unfortunately, when it comes to, healthcare delivery system in India, it's a very complex mesh. If we think that only MBBS doctors are providing healthcare and trans people are only seeking healthcare from MBBS doctors, then I think we are living in denial. We have Ayush systems who are operating. We also have unregistered medical practitioners, untrained, unlicensed medical practitioners. We also have spiritual healers, who are treating people, and all sorts of people. But unfortunately, when it comes to the legal application of convergent therapy being a professional misconduct, it's only limited to people who practice modern medicine, or what we call allopathy. If as a homeopath or an Ayurvedic practitioner, I'm practicing convergent therapy, then there is no provision in the law which can stop me. There's no provision in the law which can punish me for that. And it will have to be basically a reading of the judgments, probably in the Mental Health Care Act, to find a way towards it. But there is currently no law which penalizes practicing convergent therapy. And recently there was a documentary that was published by a journalist who came from UK, went to 2 doctors in Delhi, faking herself as a lesbian woman, and she was prescribed drugs worth 15,000 rupees by a homeopath, and promised that within a few weeks her sexual orientation will change and she'll become a straight woman. And unfortunately, the National Medical Commission's hands are tied and said it cannot do anything because the person is practicing homeopathy. So these are the kind of challenges that we are facing, and the things that we need to see in the way forward. While we speak about progressing and providing quality, equitable, inclusive healthcare, there are certain things which are really shocking. And one of them is that trans people or men having sex with men are permanently deferred from donating blood. And there is a case that's going on for that. And our government has said that there's scientific evidence to prevent trans and gay people from donating blood. That being that they are at a higher risk of HIV, and therefore they should not be donating blood. Of course, when we look at the ethics of it, when we look at the risk-benefit analysis of it, when we look at the stigmatization that a community may face because of such things, then that is something that we need to discuss a lot. I can speak for half an hour on just this topic of blood donation ban on trans and gay people. But then we need to question, do we have technology that can detect HIV in the window period? Can we really look at people and do a better counseling and find out those who may be in the window period or who may have had an unprotected sexual act? Do we need to put all people together and say that all trans people are at a higher risk of HIV? There are many trans people, for example, who are not into sex work, who may not have multiple sexual partners. A lot of trans men do not engage in penetrative sex, and therefore may not be at a higher risk of HIV. And therefore, it really, it seems the question is it just be convenient that, okay, we say all trans and MSM higher risk of HIV and just ban them? And that thing can cost someone their life, because when it comes to trans people who live within the Gharana systems, who are not part of their families, they don't have friends who are out of the trans network, from where will they get blood in the case of emergency when they need blood? It's the people from their network who are going to give blood, but unfortunately NAPO says that they can't donate. So these are the kind of questions, tough questions that we need to ask. Now let me take you through some of the broad dimensions of trans people and their need for healthcare. I'm making a statement here that trans people have a higher need of healthcare. But at the same time, I don't want this to pathologize trans people and say that trans people are diseased or that transness is a disease or trans people are unhealthy. It is our systematic discrimination which has made trans people in need of a higher healthcare. And let me tell you how. We know that when it comes to mental illnesses, suicidal ideation, suicidal attempt, or death by suicide, all of this is much higher in trans people. Not because there is a gene in them which is more active as compared to the others, but it's because like the society, the families, their own parents sometimes do not accept them. And as a coping mechanism, unhealthy coping mechanism, a lot of harmful substance use may be seen in trans people. There can be a lot of self-medication because for trans people, it may be more convenient to do self-medication than to go to a doctor who may be transphobic. And that self-medication can also include doing hormone replacement therapy. Trans men with uterus may have need for menstrual hygiene and may need care for menstrual disorders, but for them to visit, for trans men to go to a gynae OPD, itself sounds ridiculous how men can go to a gynae OPD. Since one of their traditional professions is sex work, then they have an increased risk of STI and HIV. And being low in the power hierarchy, the negotiation power that trans people have, trans sex workers have, can be extremely less. Dr. Padma had also spoken about that. There's increased risk of non-communicable diseases and cancers. Cancers also because of the use of hormone replacement therapy and because of other factors that they may not be having access to preventive checkups like pap smear or mammography. They often undergo gender affirmation services, and for that you need to go to the healthcare system. You have poor insurance coverage. Hardly 1% or maybe less than that of trans people may be having health coverage. And even when we look at the Ayushman Bharat scheme and the TG Plus card, I think not a single person has so far been able to receive benefits under that. Not a single person in entire India. Lack of family and friend support is always there, and therefore they build their own networks and gharana systems and take care of each other. And there may be poor awareness and affordability in general for healthcare, which we saw also during the time of vaccination, for example. Now, there are a lot of barriers to healthcare that trans people have, and some of them can be at the level of themselves or at the level of their family. That barrier may be because of stigma and discrimination, which can be sometimes self-stigma and discrimination or body image issues. And I'm using this picture of a trans man and his chest, which has undergone a chest reconstruction surgery. Because when we talk about, men's chest, it is not only, for example, some of our actors who post shirtless pics as the ideal men's chest, but this is also how men's chests look like. But imagine a trans man who goes for cough, cold, and fever to a doctor. The doctor says, for example, to undress. And then the trans man undresses, and then the doctor sees the scars and wonders, how is it? What is it? And then the curiosity goes on another dimension rather than, auscultating the chest of this person. And because of these experiences, or because of the perception that this experience may happen to me, I will not go to a doctor. For these illnesses. There may be past negative experiences that, 5 years back this happened to me and therefore I don't want to go to a doctor now. Or it happened to someone else, a friend of mine I know, and therefore I think it will happen to me also. Who decides for trans person seeking healthcare? Sometimes it may be their guru, sometimes it may be their family members, because in India, power and decision-making works in very curious ways. Especially when it comes to trans people. How many trans people really need mental health care? And if they need, can they decide they want to go? And if they really want to go, can they actually physically go and meet a psychiatrist? And who decides that? These are the questions. You have barriers to healthcare system in terms of no doctors being available who are trained in providing care to trans people. Even if they are available, they're only in the cities. They are not affordable because of the supply-demand imbalance. And then what's the quality of the care? There are many trans people who have lost their lives after gender-affirming surgeries. There are trans people who, because the doctors weren't available or weren't affordable, have gone to quacks or unregistered medical practitioners and gotten surgeries done by them, with disastrous consequences, sometimes even leading to death. There are unfortunately no regulating bodies that regulate gender-affirming surgeries in India. There are no SOPs, and therefore every doctor is free to experiment on trans people with the newer techniques that they may have learned in some country. And there's absolutely no control, no regulation. There are many cases which are pending in the courts about botched up surgeries of trans people, their deaths, or with disastrous consequences. But unfortunately, no real justice has been done. I want to share a recent case without divulging much details. About an intersex trans person, who is based out of a state in southern India, came to Delhi for a surgery, went to one of the corporate hospitals by doing fundraising, collecting a few lakhs of rupees, undergoing a surgery. And then an error happens in the surgery, because of which a stoma has to be created. And now for a trans person who went there for a vaginoplasty with the dream of having a new vagina, and now she has a stoma back. And, that's traumatic for her. And now for the later part of the surgery, again, she has to pay to that hospital, and there is absolutely no acceptance of negligence, or at least the courtesy of giving free treatment now for the next stage of surgery. So these are some of the instances, and these people are absolutely helpless and at the hands of the surgeons. Now, I want to highlight this message that, I know I've been talking very emotional, triggering stuff, but then this is the hard reality of a lot of trans people's lives. And, a lot of people like me and others often feel that, yes, this is pitiful, this is very bad, but what can I do? And I'm only one person, I cannot do everything. There has been hundreds of years of injustice, and what can I really do about it? And I think you can always start somewhere, maybe with something small, maybe with changing your own self, reflecting on your biases, implicit biases, your perceptions. And then that is how the change begins. So let me take you through some of the steps that I propose on how to undo this injustice. First of all, we need decriminalization, depathologization, and demedicalization. Very big in English words. Decriminalization, because remember that trans people had been criminalized under the Criminal Tribes Act in the British India, which was, of course, removed. But still, a lot of trans people are just put up into locker as habitual offenders under the Gunda Act, for example. We know that gay people who engaged in unnatural sexual offenses, especially gay men, were punished under Section 377. Then we had the Nalsa judgment, we had the Navteej Johar judgment, and changes had begun. But still, we often look at trans and MSM as people with disease, and that is why you have the blood donation guidelines, which says that, oh, we can't take blood from you. We still perform surgeries on intersex children, playing with their genitalia, changing their genitalia as per the choices of their parents and surgeons, trying to convert them into girls and boys so that they can have a tick in only one box. And these surgeries are often done for cosmetic reasons, not life-saving. And I'm sure you have read about this judgment where the court said that no surgery for this child because it's not life-saving. And let's have a medical board who will guide on which surgeries are life-saving, which are not life-saving, and who can do them. We all talk about health for all. We all talk about universal health coverage. And it's important to not just look at the numbers, but also the granular data, to look at qualitatives and the case studies. The question that we need to ask is, are we really having health for all? And especially when it comes to health for trans and gender diverse individuals. Sometimes when we look at the response of the healthcare system, especially the public healthcare system by the government towards the gender diverse people, we have the headlines coming like, okay, the Ayushman Bharat TG Plus card is being given to people and there is a 5 lakh coverage, published into hundreds of newspapers, but not a single trans person. And it's been 11 months, not a single trans person has received a single rupee out of that scheme. And therefore, it really is the question is, are we just good designers and poor implementers of the healthcare system? Gender affirming care is still not included into the essential healthcare. The HRT that trans people is not included into the essential medicines list. Trans people still face a lot of difficulty in having mental health care. And we do not have queer affirmative mental health care providers. In fact, just yesterday I was at NIMHANS, where we released a manual on queer affirmative mental health care and how that is possible. And I could still sense that, we in 2023 are still talking about, the mental health care needs of the trans and gender diverse people. When are we going to implement that? Because our lack of implementing that means that trans people continue to face mental health challenges, and some of them lose their lives because of this delay that is happening in us not being able to provide them healthcare. It's very important to also, provide competent healthcare. India is the country which produces one of the largest number of doctors in the world. We have more than 700 medical colleges, thousands of nursing colleges. But is the curricula of the healthcare systems, queer affirmative? And can just changing the curricula change the thing, everything? So for example, we have now disability inclusive curriculum, which says that for 6 hours, these competencies have to be taught. But when we look at a lot of colleges, actually, they're only teaching for 1 hour, 2 hours, and that too only, on the medical aspects of disability and not on the social or justice or equity aspects of disability. So it's important that, we talk about it. We have the national health policy. We have so many policies, but they hardly speak about gender diversity and the need of healthcare for the gender diverse people. I want to highlight 2 work that we have recently done that has focused on healthcare and gender diverse people. As some of you may be knowing, that I was working as the nodal officer of a COVID vaccination center, and we had this endeavor that we must make a center that trans people walk into, feel safe, feel accepted, take vaccines, and encourage other trans people to come to. And we were fortunate enough to do that. And we also studied during that time the structural inequities that we have in COVID-19 vaccination access and uptake amongst the trans and disability communities in India. And we looked at it from a very intersectional approach, where trans people are not just trans, but they may be also disabled and having various intersectionalities. It's also important to give control to the communities that we serve. Looking at the picture from their perspective, from their lens, from their point of view. And that is why we started this project on photo voice stories by individuals from the trans and disability communities. Through their mobile phone cameras, they took pictures of how inaccessible, these vaccination centers can be. And something that we never thought, even I come from the trans community, but I must say I'm a very privileged transgender person who is part of the healthcare system, and therefore cannot even realize the challenges that probably other trans people have in accessing healthcare. And these photo stories were actually a glimpse into the unidentified challenges. It's not just about a ramp. It's not just about, whether there is a trans toilet available or not. There is much more to it. that trans people face or disabled people face in accessing healthcare. Lastly, I want to say this, that while we are discussing this about healthcare and its interface with the gender diversity and intersectional marginalities, we must constantly keep asking question, are we including them in this discourse? And I'm really very happy that IMPRI has always ensured that people who come from the community are given the opportunity to speak on these issues, and I'm extremely thankful that they do that. But when you go back and do this process of talking about it in other groups or looking at implementing it in your work, in your research work, constantly keep asking this question: are we doing research on trans people, or are we doing research with trans people? We are not guinea pigs. Intersex people, trans people, gay people are not guinea pigs. They are not subjects of research, right? So start doing this. Are we building a new healthcare system with trans people? How do we know what are their needs, unless you listen to the trans people? So nothing about us without us is the dictum that we must always remember. I'll stop here and would really love to take questions or hear comments. Thank you.
Thank you so much, ma'am. I would request Vibhuti ma'am to give her remarks.
Dr. Aqsa said, your lecture has touched our head and heart, and I think it's very important. Your last sentence, nothing about us without us. And I think it's a very important message you are given, that we are not the subject of research. Okay, interact with us, have a meaningful dialogue, be inclusive wherever you are, whether you are in education institution or offices or in the community. I think it's an extremely important thing. I'm sure there are many, many questions because we are very proactive participants. So can we start with the first question? Aquiline John, can you start? Can you ask your question? Please unmute yourself.
Yes, ma'am. Hi, Dr. Aqsa. So my question is with regards to hidden costs of
Please introduce
gender
yourself.
affirming. Oh, sorry. My name is Aquiline John. I'm a student of psychology. My question is regarding the hidden costs of gender affirming care, especially surgery, where a lot of people going in for surgery are not informed about the complete costs involved. They are not informed that there might be further surgeries required and what those costs would be. And also about how much the post-surgical care will cost. Some of the items related to post-surgical care are not available in India very frequently, like dilators, which is the cost of getting dilators is astronomical. Almost when you compare to what it might cost in some other countries because of the cost of importing it. So is there any resource that actually accounts for the actual cost of these surgeries, and I mean, without overwhelming or scaring away somebody who might be looking for information on these surgeries?
Thank you, Aquiline. And I must say that I've been asked hundreds and hundreds of questions so far in my interaction, but this is the first time that I have received this question. So thank you for asking this very well thought of question. Just yesterday I was speaking with one of my fellow trans activist friends. You might be knowing her, Simran Bharucha. Yeah. And, we were speaking about how young trans people have a lot of demand for gender affirming surgery. There's a lot of demand from young trans people, especially sometimes less than 18 years, but also let's say in the age group of 18 to 25 years for a quick transition, a surgical transition, and to become the perfect man or the perfect woman. And while there is a huge amount of cost, and I always say this for the purpose of contrast, that gender affirming surgery is more costly than cardiac surgeries or neurosurgeries in India. It can cost anywhere between 500,000 to 2 million rupees, depending upon the number of surgeries that you want to undergo. But I think what, while this costing and economics is very important, and you've correctly mentioned about the cost of dilators, there's also some work, for example, on the binders and the projects where the trans men who have undergone chest reconstructive surgery and therefore no longer need the binders are donating it to other people. I think one important aspect that we must first discuss is the cost that some people may pay in terms of life, in terms of disability, because they undergo surgery. These surgeries are life-saving surgeries. Gender dysphoria can kill people, and gender-affirming surgeries can save people from gender dysphoria. But at the same time, I think a lot of trans people do not have the adequate information to take an informed decision with reference to surgeries. You see a lot of crowdfunding now happening on platforms like Milap for people for gender affirming surgeries, and they may be able to, garner, let's say, 4-5 lakh rupees from them. But from where do they get the information on what are the risks versus benefit of this surgery? What really can I expect practically out of this surgery? So there are a lot of myths and misconceptions that people have. They may go for shortcuts, and that can cost their lives. So I think it's very important that when we speak about informed consent, how much information do people really have? How much informed decision making is involved? That's a conversation that we must have. Again, the topic that you raised about costing is very important, because when the government says in the Ayushman Bharat scheme that we'll give you 5 lakh rupees for gender affirming surgery, how that figure of 5 lakhs was derived? And is surgery the end of it? As you correctly mentioned, there's a lot of stuff that is needed post-op in terms of gender affirming care, and that is not covered under these packages. So that's really, one of the topics for research, and I hope someone takes up that. I hope I have tried and answered you.
Yes, doctor. Is there any particular resource available at the moment that comes close?
I haven't come across anything. Some trans men have, of course, looked at the cost of binders, etc., and T injections, that the testosterone injections, but not really much research available on that in the Indian context.
Durga Valmiji, do you want to ask your question?
Hello.
Sasha Nijharaji, you can go on with your question.
Thank you. Thank you, Aqsa ma'am, for the great presentation. And I really want to come as a person who herself is trying to make a difference, through public relations. It is again a very personal anecdote from my end also, that I started working in communications and public relations specifically for social impact organizations, so that I can work with more organizations. I don't want to reach out to only one set of people and reach out to only lakhs of people. This community gives me a space where I can work with 7-8 organizations together and reach out to much larger organizations in terms of mental health, helping marginalized communities get their rights. So I completely agree and also understand where you're coming from, and compassion and sensitivity, I think, are the primary requirements for us to be there on humanitarian grounds for other people. And I have actually 2 questions. First, in your presentation, you said that, trans people are on scientific grounds are banned to give blood, to donate blood. But as an Indian, or as the reports that we've read very commonly, is that reproductive health knowledge is anyway very low among Indians. So the issue of maybe an HIV or any other STD can be like in among any person. So can't it be that there is a blanket policy to undergo a regular health checkup within a quarter before blood donation, so that everybody is aware if they have a certain issue that can cause further issues during blood donation? So can't there be anything like that?
You said you have 2 questions, so
Yes.
that's one.
Yes. So should I ask the second one also?
Yes, yes.
All right. So, also you mentioned that trans people are not able to go to gynae. So, is that a social construct, or there is a need to upskill healthcare providers to treat them better or with much larger sensitivity?
Thank you, Sasha. And as I mentioned, the question on blood donation is going to require a little longer answer, but let me try and give a shorter version of it. I've mentioned about it in an article for India Spent and another article. I'll share the links to those articles in the groups. You can refer to the detailed views of various ethicists also on this. Now, we need to understand that there is a blood donation policy which looks at, having safe blood donors. And that is why we are having a policy of voluntary blood donation by people and not purchasing blood. And there's also the rule that every blood and blood product before we transfuse will be tested for a few blood-borne diseases like HIV, hepatitis B, hepatitis C, malaria, and syphilis. So whether you take blood from X, Y, or Z, it is gonna undergo an HIV test. And if it tests positive for that, the product tests positive for that, then that blood product and the bag is going to be discarded. But then there is a cost involved to it because you have already collected blood, you have used a blood bag for it, you have done the testing, and now you have to throw it, right? Second part is that there may be some people who may be in the window period and our tests may not be able to detect those people. And then the blood product may carry HIV. And as you know that through blood transfusion, the success of transmission of HIV is nearly 80 to 90%. The third thing that we need to understand is that before you take someone as a donor, there is a session where the counselor asks you questions on, have you had in the last few months unsafe or unprotected sex, or for example, taken injections, etc. We don't really know how many people answer that honestly, and therefore, as a matter of, I would say, convenience, this decision was taken that since trans people have one of the highest rates of HIV amongst all the higher risk groups, since MSM, that is men having sex with men, have a higher risk of HIV, since injecting drug users have a higher risk of HIV, they will not be allowed to donate blood. Saves a lot of our efforts because then we don't have to do tests that can detect HIV even during the window period. Then we don't have to go for a very detailed counseling session. And it's easy, right? I mean, you just remove a community and we say that we assume that the blood products are going to be safe. But a lot of countries now, for example, US, UK, Canada, have changed their guidelines and they are now allowing especially gay men to donate blood. With these certain guidelines that in the last 3 months, they should not have had an unprotected sex, etc. And I think there's enough technology now that we can use. And if anyways you get a blood from a trans person which is HIV infected, you are going to throw that away. You're going to not donate that to anyone. So it's not really much of harm. And therefore, this has been challenged in the court. And I really hope that the court takes a very measured view on this and allows trans people to donate blood. As I mentioned, I'll share the links to the articles and there will be a more detailed answer to that over them.
You can do even on chat box because chat box has that facility of sharing the link.
Yes. I'll try and share there also because I think there's a group also now, WhatsApp group, so
yes.
I can do that. Second is, the question about trans men or non-binary people accessing gynecological services in India. We need to understand that, saying that gynecological services means these are for men, women only. For a lot of gynae OPDs, especially when we move away from the urban centers, there is actually no concept of a man coming to a gynae OPD as a client, right? A lot of providers have never attended to trans men in their entire lives. Many gynecologists in our interactions have mentioned that they've never had a trans man come to their OPD. And therefore, there is no experience, for example, on how to take history, on how to do examination, how to do a pap smear. in many of the other advanced societies, there are now guidelines on how doing a pap smear may be more different in trans men as compared to women. Because in trans men, there is less lubrication, for example, and you may need more lubricant to be applied to do a pap smear. But if you look at the training in gynecology, there is absolutely no teaching on doing a pap smear, for example, on a trans man, or a trans man who comes to you for menstrual disorders, or a trans man who comes after hysterectomy, for example. So I would say there is a lot of need of revising the curricula for the upcoming gynecologists. There's also need for strong bodies like Foxy, who have been working with gynecs to now do some kind of CMEs on taking care of gynae patients. And I think in general now the gynae OPD needs to be made probably gender neutral. They have started treating infertility patients, and they often treat couples rather than women when speaking of infertility. And I think it's time now to open door to also trans men as their clients.
Thank you so much, ma'am. It's very informative.
Roshni Babuji, you can go ahead with your question.
Thank you, Fiza. I was just making an observation from what Dr. Mala Ramanathan told yesterday, that, as public health professionals, we have a responsibility to ask the right question. And there were certain incidences that, that came to my mind. When the Me Too movement was going on, I was part of a professional group, and there was a statistics that was released that said that 13% of the rapes claimed by women are false, right? And the entire conversation was shifted to that 13% rape cases are false rather than 87 cases are positive. This was I felt like it was a calculated move to take the narrative away from what is being what the actual issue is, and diverting it. So for me, I feel as a public health researcher, we have a huge responsibility on our shoulders to ask the right question. We use the principle of utilitarianism when it comes to public health. That's public health ethics, correct? And we should know how we need to apply this principle in action, in our practice. I just thought of sharing this one with the group.
Yeah. Dr. Veena Vaswani, would you like to respond? Hello.
Yes, ma'am. I'd like to respond that it is very true that we want to remove the focus. Thanks, Aqsa, for a wonderful presentation. So we just try to distract it, but that is not addressing the truth. And truth is also the fact that, like Aqsa's opening statement, what we don't know, it is the expanse of my knowledge. And if I don't know something, it doesn't mean it doesn't exist. And then to say that what I know is only the knowledge and what I don't know, it just doesn't matter. And that's what exactly we've been doing with the epistemology of knowledge. We need to reconfirm, re-understand how we have gone wrong in looking at only two genders, making them in watertight compartments as though we have been correct. In fact, if there is a reparation, we need to say sorry for the way we have been believing that only two genders exist. Imagine the amount of injustice we have heaped for centuries together. And then using those as our example, an exemplar culturally that this is our culture. But you made a wrong decision. You're sticking to it. So I think it's imperative for us to know that if you don't know something, try to find out and be humble enough to accept that we are trying to find out. We are trying to inculcate in the curriculum. We want to make an enriched curriculum that serves everybody across, marginalized and every group included, than saying that this is how it is, because the textbooks also took too long a time, too long. And it was more of lip service. Yes, we feel bad. We shouldn't be done, but it will still continue to be done. So I think it's a good this thing to look at it, that we ourselves need to learn by introspection, reflection, and especially in medical education, every person who is a role model should emulate this, imbue the same respect for human person across genders and cultures and communities. So I greatly agree with every word that is said by Aqsa.
Thank you so much, ma'am. I would request Ekperin Jonji to ask her questions.
Hi, sorry, I have a couple more questions. So the first question is with regards to the availability of the new, I mean, I keep reading about the newer class of antiretroviral therapy drugs available for HIV in different countries. And one is I want to know if they have become affordably available in India. And secondly, what is, I mean, having seen what it takes to seek help from the government healthcare system for HIV therapy. I mean, I don't think people are informed what is the medicine that they are given. They are just given the medicine and told that this is to be taken these times, and these are the side effects that you will face. That is what is the, I mean, from my experience, this has been the case in most places. So I just wanted to know if there has been a newer class of medicines that have been that are being used in government hospitals, or if the guidelines around informing patients about what the medication is that they are consuming and has become more robust.
If there's someone more qualified to answer this question, then I'll request them. Otherwise, I'll try and take it up.
No, you only will have to try. I'm a social scientist.
Yeah. So, I think, again, a very relevant question, especially since the gender diverse population is at a higher risk of HIV in India. I want to tell you, a small incident that I observed. So we were going to the NACO's Delhi office, their headquarters. And as soon as we came out of the lift and we were trying to enter their office, we saw that there are at least 50 people who are waiting in the corridor. They are sitting there, lying down there. And we were wondering who are these people outside the office of NACO. And then we were told that these are PLHIV who are sitting in protest outside the office of NACO because they are not being provided drugs, which is promised to them as free ART. And for a very long period of time that stretched for months and months, people living with HIV were not provided with ART medications in India. And this was happening in 2023. And I'm talking about first line ART. While the question is about second line ART and third line ART, yes, there are certain centers of excellence which have now started providing second line and third line ART. But I think it's not, just that, oh, we have one center that provides second line ART. It's like, is every PLHIV in this country guaranteed the treatment that they need? Since that is under the HIV/AIDS Act, we are saying that we want, their rights to be given, but it does not promise the free ART to all PLHIV. And that is a lacuna, that there is no legal right that PLHIV have. So I think we unfortunately are still fighting for right to first line ART, forget about third line ART. The second concern that I want to address is the access to pre-exposure prophylaxis or post-exposure prophylaxis. We know that pre-exposure prophylaxis, that is taking these antiretroviral medications before someone gets exposed to HIV, or taking post-exposure prophylaxis after someone gets exposed. And this is not only limited to cases of sexual assault. Of course, in case of sexual assault, the government does provide, but in other cases. And currently, there is no provision of pre or post-exposure prophylaxis in these scenarios. And I think unless we do that, that our aim of zero HIV transmission is by 2030 is not going to be achieved. So a lot of work that needs to be done. When it comes to counseling on ART, I think, again, the issue of quality is a lot there. What is the quality of these counseling sessions, how queer affirmative they are, how sensitive they are, especially since a lot of people who are PLHIV have a lot of additional marginalizations of class, language, gender, caste even. So yes, a lot of work that needs to be done to access of at least first line ART and also to the counseling practices.
Thank you. I actually did not know that that free ART is not a right. I was under the assumption that it is something that is provided, because at least from what I'd seen
so if I remember the line by line of HIV, is that correct? It says the government will try to provide ART, but there is no commitment, legal commitment there.
But at a subnational level?
So some of the states are doing some good work, I must say, in provision of ART. But I must also admit this, that now we have entered a phase of complacency with reference to HIV. So when it comes to usage of condom, for example, it has decreased in the recent times. When it comes to testing for HIV, that has decreased, because somehow we think that HIV is no longer deadly disease. It's just manageable. There's also a lot of chem sex that now happens, that is sex done under the influence of chemical substances, and that has an effect on your use of protection. So lot of work there. Maybe we can have a session with an expert who works in this field on this.
Thank you, Dr. Aqsa, you're clarified. We don't allow anonymous attendees, so you can ask your question, but you will have to introduce yourself.
Ma'am, I have one more question. Is it okay if I ask?
Okay, yeah, please ask.
Firstly, I read that the highest, we are practically living in a pandemic of HIV. There are more cases now than there were in the 70s and 80s worldwide of HIV. That being said, I'll move to the other question, which is that so I've noticed that a lot of the hysteria that happens around many issues in the US get translated over to India. There is a major issue related to transgender care in the US, and recently there have been some things that have easily trickled down to India, and I'm wondering if there is a way to stave that hysteria off, especially in the medical care field.
Yeah, hi. I'd read that question, though I'll try and avoid the usage of the word hysteria, because it has a gendered connotation of its reference. Hysteria comes from the word hystero, that is uterus, and it said that women are hysterical. So, but yes, you are very right that what we are seeing in terms of the backlash against the trans community in some countries like United States is really scary and worrying. But at the same time, I think these two countries like US or India just cannot be compared. There are reasons for that. Let me just tell you a few differences. One is when it comes to legal protection, India is one of the few countries to have a transgender act, which has a structure of legal protection for trans people. In United States, you don't have that. In fact, in the last year, hundreds of bills have been introduced in various states to ban children from trans toilets, to not allow access to gender affirming care to trans adolescents, etc. So while in India you have a protective legal framework, over there you have lots and lots of introduction of anti-trans bills that is happening. Second is when we come to the access to the healthcare by trans people in India versus the access to healthcare by trans and non-binary folks in US, we just can't compare. In terms of, I would say in India, we do not even have a minuscule of the services what is available to a trans person in United States, the quality of the service, etc. And that is why when they have a certain standard of quality that they expect, if that is not being provided, then there is a lot of hue and cry that is being maintained. So for example, there's a lot of hue and cry that we get to hear about trans adolescents not being allowed puberty blockers in United States. Now compare that with the condition of trans adolescents in India. There are thousands and thousands of trans adolescents in India. How many of them even have access to puberty blockers or trans counseling services, or just the understanding that they're trans? So we are at that stage, and the global north is somewhere over there where there is voices why trans adolescents are not getting puberty blockers. Here we are not even thinking about trans adolescents. So yes, but I think there is a distinct danger that we see, and it's not just limited to United States. We have another example in Pakistan that I would like to give. Since it's a neighboring country, cultural ethos of the socio-ethnic groups like the Kinnar communities are same. Pakistan was one country which introduced the Trans Act just before us. And that was again seen as a landmark, that in South Asia, trans people are given legal protection. But now there is a, petition in their court, which is trying to undo that and saying that only intersex people should be allowed surgeries and not trans people. So I think it's very important lesson, whether from US or from the Pakistani society, that we should not get complacent with our wins. That wow, we have a Trans Act in India and now we can only progress further. No, there are dangers that we must be aware of that can take us again back. And if you followed the discussions around the marriage equality case that was there in Supreme Court, and the arguments that came from the people who are opposing marriage equality, then we've seen how much of transphobia was there, right? So I think we have made some progress in terms of legal framework. A lot needs to be done on the health side, but we should never get complacent and think that we're only going to progress. There are real dangers, and we must be proactively fighting for them.
Ma'am Garima Agarwal, can you go ahead? Hello.
Hi. Thank you, Professor Patel. Hi, Dr. Aqsa. It's so lovely to hear from you. I'm Garima, and I'm a researcher, a qualitative researcher at a research consultancy here in Delhi. I've had the opportunity of working across some key social domains like SRHR, nutrition, climate conversations in the past. So I have a very Khurafati researcher mind. And I was just wondering about this very interesting piece of research that you shared with us, the photo voice research with Sangat India. Just trying to understand, firstly, whether this research piece exists in public domain, so we can refer to it and read it. If not, then what kind of methodology was utilized? What was the geographic sort of coverage that was undertaken? How were the participants briefed? All sorts of questions I have. Whatever time you have to, shed light on this piece would be great.
Yeah, so I mean, it was a very interesting learning thing for me also, because I had not been engaged in a photo voice kind of research previously. No, it's the process of photo voice story has not yet been published. I hope that will happen in the next 1 year. But the booklet, which has the photographs and the stories along with them, is published. It's on the Sangat website. I'll also try and share here. And just to briefly, tell you about the methodology that we have used, is that this predominantly included trans and disabled people from cities like Delhi, Pune, and Bhopal. And the trans people were trained on use of camera, on use of mobile photography, trying to ensure that we only give the technical aspect and not what to click or, what to tell, because we wanted it to be their stories. And then they were put together into a group where multiple sessions happened on what we are trying to achieve by this, because there are also copyright issues when you do photo voice stories. do you need consent of the people whose photograph you are taking? Do you need permissions from the vaccination centers where you are taking the photographs? Then we also had a buddy system. That is, there are some trans people who needed a partner, a photography partner. And there are also persons, for example, blind people who needed a buddy when they are taking photographs. So we also had blind photographers, for example, in this project. We had to also ensure that the buddy does not influence, the research participants who are now not just research participants, but also researchers, because they are collecting the data. So it was like a dual role. So a very interesting methodology. There have been similar photo voice studies done for tuberculosis research. I'll share the product or the booklet that we developed out of it, and hopefully the methodology paper will come in a year. Thank you.
Thank you. That sounds amazing.
So, Amruta Girish, can you unmute and ask your question?
Yeah. Good evening, ma'am. Thank you for the lovely session. I am a development professional working in Karnataka, and I've worked closely with the transgender community here in skill development and livelihoods. My question was, how can effective gender sensitization programs be conducted for students and professionals, teachers, law enforcement, medical practitioners? Do you recommend any resources, especially in the regional languages like Kannada? Are there any in the public domain that can be translated, or do any resources exist already? And how can this be effectively delivered?
Yeah, that's I can write a book on that. Yeah, but I'll try to answer briefly. So one is, as you correctly mentioned, these are the people with whom a lot of sensitization is needed, right from law enforcement agencies to school children. I want to mention about one tricky area, that is working with school children or with people less than 18 years of age in the schools and talking to them about sex, sexuality, and gender. It's been an issue that's mired in controversy. As you know, there was an NCERT booklet for trainers, for the teachers to sensitize them on how to talk to children about these issues. But unfortunately, it was taken from the website based on the complaint by National Commission for Protection of Child Rights. So I would say it's a difficult area to talk to children about gender, sex, sexuality in India, because we are very touchy about these issues. But there has been some progress. There is something called as a School Health and Wellness Program that's launched by the Adolescent Health Division of Ministry of Health and Family Welfare in collaboration with UNICEF and NCERT. And they are doing currently pilot implementation in multiple districts across India, including in Karnataka, where they've taken like a couple of districts. They have one teacher who is trained into providing these sessions, and then there are modular sessions, for example, that talk about gender identity, that talk about sexual well-being, menstrual hygiene, in addition to other modules also, which are on health and well-being. I think a copy of that should be available on the Ministry of Health and Family Welfare website. If not, I'll try and find and share. It's in English only, so I don't think there is a Kannada version available of that. Similarly, as I was mentioning yesterday, we released at NIMHANS a booklet on psychosocial well-being of queer folks. But that's also a more generic module that can be used with, let's say, school children, with policymakers, with educators, etc. And I can share a copy of that also. It is also only in English, though they have a plan, since NIMHANS is unfortunately Karnataka, to translate it into Kannada. But I can share the English version definitely. Yeah.
So now we have
in terms of strategies, I mean, that would be another 1 hour of talk.
Okay, now we have anonymous attendee. You'll have to identify yourself and you can ask your question. Hello. Are you there? Okay, I read the question. What kind of health concerns do individuals who identify as asexual have? We don't talk much about asexuality as a sexual orientation. What kind of mental health concerns do asexual individuals have? I hope my question is not insensitive. I wish to stay anonymous.
I think that's a question very valid, not often asked about asexuality. Definitely, when we speak about LGBTQIA plus, that A over there is referring to asexual or aromantic individuals. We know that heterosexual are those who are attracted to people of other sex, homosexual, same. Asexual are those who are not sexually, romantically, physically attracted to people of any sex. But unfortunately, we assume in the normative, paradigm that everyone has sexual attraction to someone, So we first fought for normalizing homosexual attraction. And now asexuals are minority within the queer community. And they are fighting for saying this, that not all queer people are sexually attracted to others. So yes, I would say there's a lot of taboo and even discrimination against asexual people within the queer community, because often queerness is shown as something which is hypersexual. But when it comes to asexual people, they do not derive pleasure the way that a typical person does. And for them to socialize, for example, in the get-togethers of queer people, when it comes to dating apps, when it comes to having a relationship for asexual people, it's absolutely difficult. Similarly, when they go to a healthcare provider, all healthcare people assume that queer folks must be having a lot of sex, they must be having a lot of unsafe or unprotected sex. And for them, the imagination that there can be queer people who are not interested in sex or not in the way that we think of is not part of their imagination. So that happens, and I think often asexual people are not included in conversations around the healthcare needs of queer folks. So yes, that's something that we need to include in our discourse. Yeah.
Thank you so much, ma'am. I would like Professor Vibhuti Patel to now give the concluding remarks for today's.
I think I don't have much to say, but I think I must say that both the lectures by Dr. Padma Deosthali, extremely gender responsive, and also the way she gave the nuanced understanding of varied forms of gender-based violence, starting from violence against, difference between violence against women and gender-based violence, and how the health system is responding, what kind of stereotypes are existing even among the medical professionals, and why we need to, as I think Dr. Aqsa also said, we cannot be complacent. This exercise has to go on continuously. Awareness must happen in the community, in the society, and in the medical system. Changes in the medical curriculum, which is extremely important. Both the speakers talked about it, and Dr. Aqsa Sheikh's lecture was extremely very, very educative for us, because it expanded our horizon. So many things which we have never which we have never heard, or which we have never experienced, or which we have never dealt with in our life as a professional, or as a teacher, or as a person in social movement working with the community. I think they have been clarified, and it will go a long way. But there is also an appeal that, because all the participants are extremely active, articulate, and this thing, so I think taking these messages in the regional language becomes a very important mandate, because a lot of brutalization happens at that level. So I think all of us will also have to be translator. I remember when I became a feminist, first thing I said that if I don't want to become just keep feminism only as an elite occupation, then I think we'll have to translate. So we started, translation become equally important agenda for us. So I think this is the demystification of the whole knowledge. And as Dr. Veena Vaswani told us, that whole epistemology is full of misogyny. How to engender our way of thinking so that all these phobia, prejudices, hatred, and extremely brutal violence that we face in our day-to-day life against all types of minorities and especially with the sexual minorities. I think it's very important. I think whole gender spectrum. In fact, the next time we will ask Dr. Aqsa Shaikh to explain to us what is this gender spectrum. We have been hearing it in a popular parlance. Now they write even in the newspapers about it. So it is very important to understand, and it will have a humanizing influence on all of us. Thank you very much. Yeah.
Thank you so much, ma'am. So as we have come to the end of the day 3 of Healthcare and Gender Equity, an online international Monsoon school program, a 4-day immersive online hands-on certificate training course, I, Fiza Mahajan, visiting researcher at IMPRI, Impact and Policy Research Institute, would like to propose the formal vote of thanks on behalf of IMPRI, Gender Impact Studies Center, New Delhi. We are grateful to our experts for the day 3 session, Dr. Padma Deosthali, Dr. Aqsa Shaikh, Dr. Veena Vaswani, and Professor Vibhuti Patel for taking out their valuable time and giving us an opportunity to learn from this online certificate program. We thank all our participants who have raised pertinent questions and actively participated in today's deliberation. We look forward to welcoming you tomorrow at 6 p.m. for the 4th and final day of the certification course by distinguished experts Dr. Amar Jesani, Professor Uma Kulkarni, and Professor Veena Vaswani. We are grateful if you are watching us later on YouTube or listening to us on our various podcasts or reading our publications. We hope you continue to join in future to our IMPRI Web Policy Talk and Web Policy Learning. I wish you all a very good day. Thank you.
Thank you.
Thank you.
Thank you. Good night.
Good night.
Thank you.